Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session, I'll be discussing the quiz which I have posted on 12th of May on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So every day I'm posting the quiz on my Telegram channel, and on the subsequent day I'm posting the discussion as well. So as a part of it, let me discuss the first question. So, which of the following is not an early sign of the extramedullary spinal tumor? The options are bladder involvement, touch and proprioception lost on the side of lesion, muscle dystrophy below the lesion, none of the above. Now, if you take this extramedullary tumors, where do they originate from? The extramedullary tumors are those which originate from the epidural space, or these are the one which are present within the epidural space. Now, whatever the structures which are present within the epidural space or near to the epidural space, they get compressed first. Like for example, you take touch and proprioception. It is being lost on the side of lesion. So touch and proprioception, it is carried by the dorsal columns which are present very near to the epidural space. So definitely your touch and proprioception, it is lost on the side of lesion in the early stage. And you take the muscle dystrophy below the lesion. So definitely, because at the level of lesion in the spinal cord you have LMN features, below the level of lesion you will have the UMN features. Okay, so there will be muscle dystrophy, but that muscle dystrophy will be in the form of diffuse atrophy that you will have in patients with the extramedullary spinal tumor. That will be diffuse atrophy. Whereas you take the bladder involvement, this is not an early sign. Why? Because the involvement of the bladder as an early sign, it is seen in case of the intramedullary tumors, but not in case of the extramedullary tumors. Now, why is that? Is because the fibers which are controlling the bladder, they are present not near to the epidural space. They are present within the center of the spinal cord. And that is the reason why the bladder involvement will not be early in patients with extramedullary spinal tumor. Whereas in case of intramedullary spinal tumors, the bladder involvement can be early, right? So that's the first question. Then you see the second question. All of the following features are seen in myelopathies except facial sensory impairment, brisk jaw jerks, brisk pectoral jerks, then bladder involvement. So you take the facial sensory sensations, they are carried by the fifth nerve. Okay, that is the trigeminal nerve. And where will be the nucleus of the trigeminal nerve? The nucleus of the trigeminal nerve, it is present within the pons. And from the pons, right, it also extends to the lower part of the pons, and it extends to the medulla oblongata. And we have the spinal nucleus, and this particular spinal nucleus of the trigeminal nerve, it also extends up to C3 or C4. So the nucleus of the trigeminal nerve, which carry the sensory sensations of the face, they extend up to C3 to C4. Now what do you mean by the word myelopathy? Where there is spinal cord lesion. And if there is lesion at around C1, C2, C3, then the spinal nucleus can get damaged and the facial sensory impairment can be there. So first option is not correct because the question asked is except. Now you take the brisk jaw jerk. Brisk jaw jerk, if you see, what is the afferent for the jaw jerk? That is the fifth nerve. And what is the efferent for the jaw jerk? That is again the fifth nerve. The afferent will be the sensory component. The efferent will be the motor component of the fifth nerve. And where is the center of this jaw jerk? The center of the jaw jerk is present within the pons. So in order to have the development of the brisk jaw jerk, the pathology should be at the level of brainstem, and that too at the level of pons. Okay, so remember, the brisk jaw jerk will not be seen in patients with the myelopathies. Now what about the brisk pectoral jerks? See, for the pectoral jerk, you need to know like where will be the center or the reflex is mediated by. So the pectoral jerk, the reflex is mediated by medial and as well as lateral thoracic nerves, right? Mediated by medial and lateral thoracic nerves. And what is the root value of this medial and lateral thoracic nerves? It is around C5 to T1. Okay, so C5 to T1, it is again the part of the spinal cord. So if there is myelopathy involving C5 to T1, there can be a brisk pectoral jerk. Okay, so brisk pectoral jerk is a part of your myelopathy. Then what about the bladder involvement? See, bladder control is being done by what? It is being controlled by the autonomic nervous system, right? And this autonomic nervous system, it relays via the spinal cord, right? It relays via the spinal cord. So remember, whenever there is myelopathy, there can be bladder involvement also. So the answer in this question is the brisk jaw jerk is not the feature of myelopathy. The brisk jaw jerk can be there when the pathology is at the level of the brainstem or above the brainstem. Okay, particularly above the brainstem, not even at the brainstem. Above the brainstem, if there is pathology, then you will have the brisk jaw jerk. Okay, brisk jaw jerk I seen whenever there is upper motor neuron involvement. Okay, right. So that is the second question. Then you see the third question. Which of the following is not true regarding cervical syringomyelia? So syringomyelia is what? It is nothing but the cavity which is being formed within the central part of the spinal cord. So at the level of the cervical region, you will have element features, and below the level of the cervical region, you will have upper motor neuron signs. Okay, so at the level of cervical, you will have element. Below the level of cervical, you will have upper motor neuron sign. So you take this extensor plantar reflex. Yes, this will be there because this will be the upper motor neuron sign. And what about the absent biceps jerk? Yes, even this also will be there in case of cervical syringomyelia, because absent bicep jerk to have, the individual should be having the element lesion. And in cervical syringomyelia, there can be pathology at the level of C5. So absent bicep jerk can be there. And the characteristic feature of the syringomyelia is the painless burning of the hand. So these patients with syringomyelia, they will have what is called as dissociative anesthesia, right? Where there will be loss of thermal sensation, right? Loss of the thermal sensation, but the posterior column sensations will be intact. So painless burning of the hand will be there. Now, whenever there is pathology at the cervical area, remember, you will not have the hypertrophy of the abductor pollicis brevis. You will notice that there is atrophy of the abductor pollicis brevis. So the correct answer here is C, because the question asked is which of the following is not true. The answer in this question is C. Now we will move on to the fourth question. Right. Which of the following is a feature of the upper motor neuron lesion? So this is basically a physiology question. The options are disuse atrophy, denervation atrophy, fasciculations, plantar reflex is being absent. So the BCD, these are the element signs, right? So the atrophy, the denervation atrophy means what? The lower motor neuron which is supplying to the muscle is damaged. And once this lower motor neuron is damaged, that is called as the denervation atrophy. And what are these fasciculations? These fasciculations, they are involuntary movements, right? They are the involuntary movements which are present due to the lower motor neuron lesion. And it is due to contraction of or irritation of the single muscle fiber. And the plantar reflex will be absent. Whereas you take in case of the upper motor neuron lesion, you will have the presence of the Babinski sign. Whereas in lower motor neuron lesion, the plantar reflex is completely absent, or the plantars will be mute. And remember, in upper motor neuron lesion, what is that you will have is disuse atrophy is what you will have. Why is that? Because in upper motor neuron lesion, there will be spasticity, right? There will be spasticity of the muscles. Now, because of the spasticity of the muscles, there will be disuse atrophy in upper motor neuron lesion. So the correct answer is A. Now moving on to the last question. Dermatome of the inguinal ligament is. This is basically an anatomy question. The options are L1, T12, L2, T10. So for the inguinal ligament, the dermatome is T12. Right? So these are the 5 questions of the quiz which I have posted on 12th of May on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So you can join to my channel for everyday daily quiz discussion. Thank you very much. See you tomorrow again.